Welcome to the Myeloma Matters podcast, hosted by the Multiple Myeloma Research Foundation, focusing on patients' experiences with and perspectives on multiple myeloma topics that matter to anyone affected by this blood cancer. In today's podcast, you'll learn about the side effects associated with CAR T-cell and bispecific antibody therapies, sometimes known as T-cell engagers. You'll also hear from a patient and a nurse practitioner who will talk about how these treatments are administered and about what it's like to be on these therapies. Please note that every myeloma patient is unique. The information in this podcast is not intended to replace the services or advice of trained healthcare professionals. Please consult with your healthcare team or contact the MMRF Patient Navigation Center at 1-888-841-6673 if you have specific questions about your health. If you'd like to support this podcast series, we'd love for you to leave a comment or review wherever you get your podcasts. Chimeric antigen receptor T cells, or CAR T cells as they are commonly called, are a form of cellular therapy and are made from a multiple myeloma patient's own T cells. After these cells are collected from a patient's blood, they are modified in a lab so that they are better able to identify and attack myeloma cells. Once returned to the patient's body, these improved T cells, that is, the CAR T cells, seek out and destroy myeloma cells. To learn more about the process of receiving CAR T cell therapy, we will first hear from Dennis Verducci, an advanced practice nurse practitioner who specializes in myeloma treatment. Dennis has been working as an oncology provider since he graduated from nursing school in 2008.
When I was in nursing school, this was back in 2008. When I was in nursing school, I actually had the intention on doing pediatrics. But unfortunately, while I was in nursing school, my father got diagnosed with stage 4 colon cancer that had already metastasized to the liver. So when he was diagnosed, he unfortunately never got to see me graduate because he passed away. But from there, I decided I was going to shift gears and focus on oncology for the rest of my career. So that's why I got into oncology.
Dennis started working in a stem cell transplant unit where the majority of his patients were receiving myeloma treatment.
I got very intrigued by the disease. And when the chief of the outpatient myeloma program asked me to be his NP because he knew I was in school, I thought it was a very good opportunity to kind of dig more into just myeloma. And that's why I took the position to be his outpatient NP. And that's where I really learned how patients were worked up, diagnosed. I learned the ins and outs of myeloma when I went outpatient. So, and then as I started learning more about the disease, I just became super intrigued by it because it is such a sneaky disease. It's a very gray area disease. It's not a very black and white disease. And that interested me a lot.
Since Dennis started working in multiple myeloma, treatment options for the disease have changed dramatically.
When I first started in the field, there was not many treatments left, and the prognosis was very, very poor for myeloma patients. Transplant was really the gold standard, and I think back then it was definitely the best option for these patients because it was the only thing we could give them to give them some sort of a long remission or a lengthy remission. But the drugs that we had to treat the disease were actually not very good, and there was not really a lot of options for these patients.
Today, a variety of treatment options are available for people living with multiple myeloma, including cellular therapies such as CAR T-cell therapy. As an advanced practice provider, Dennis works closely with both the cellular therapy and transplant teams at his clinic. The processes involved in administering cellular therapy and performing an autologous stem cell transplant are very different and are thus handled by separate teams.
A lot of people think because they're both under the same doctor group, cellular therapy and transplant team, that they're similar therapies and they're similar side effect profiles. It's actually not the case.
After completing induction therapy with either a 3 or 4 drug combination, a myeloma patient who elects to undergo a stem cell transplant will begin with apheresis, which is the collection of stem cells. Stem cells, a type of cell found in the bone marrow, can develop into many different types of blood cells. To make sure that enough stem cells can be collected, Patients may be given drugs that boost the production of these cells, a process known as mobilization. Once the stem cells are collected, they are frozen and stored for later use. At some point after apheresis, the patient is given an infusion of melphalan, a high-dose chemotherapy drug that kills most of the myeloma cells still remaining in the body, but also wipes out most of the healthy cells in and around the bone marrow.
So when a patient gets an autologous stem cell transplant, they get a drug called melphalan, which is a very old school chemotherapy. It's an alkylating agent, very old school. And what the purpose of this high dose chemotherapy is it's supposed to obliterate the bone marrow, but it also is going to kill all the rapidly dividing cells, such as your hair follicles. That's why patients lose their hair with transplant, their GI tract. They can get some mouth sores, they can get some diarrhea. And it also targets the bone marrow. So it's supposed to pretty much just kind of wipe out your bone marrow. And you can get infections, the blood counts can drop.
The day after melphalan is given, the patient's stem cells are thawed and infused back into him or her.
Now, the purpose of getting the stem cells back, I think there's some confusion that the stem cells go against the cancer. It's actually not the case. All the anti-myeloma effect is being done by the melphalan. The stem cells that the patient gets back doesn't do anything for the myeloma. But what it does is the stem cells repopulate in the bone marrow so you can populate healthy blood cells. So in other words, if you got high-dose melphalan and you didn't get your stem cells back, that patient would be transfusion dependent because they have no bone marrow. So you give the high-dose melphalan, the purpose of giving the stem cells back is so that way the patient can populate a normal, healthy bone marrow. I would say, in my experience, it probably takes a good 2 to 3 months for patients to kind of get back to their baseline. They'll probably lose weight in that period. I would say probably around 2 to 3 months, they'll get back to their baseline. And then every month after that, it should start to get better and better.
CAR T cells, on the other hand, are engineered from a patient's own immune cells. The first step involves collecting T cells from the patient's blood and sending them to a lab. The process is similar to stem cell apheresis. However, the cells that are collected for CAR T cell therapy cannot be used for a stem cell transplant.
Fast forward now to CAR T cell therapy. So what CAR T cell therapy is the patient gets their T cells extracted from their blood. Those T cells are now manipulated and engineered in a lab. And then when the patient gets the cells back, they get what's called lymphodepleting chemotherapy. So basically, they get this chemotherapy that's not as ablative as the melphalan, but the purpose of this chemotherapy is to kind of wipe out your normal T cells. Then you get the infusion of the engineered T cells, and those T cells go against your myeloma. So in the transplant, the stem cells don't do anything for the myeloma, but in CAR T cells, the T cells are actually engineered to go against the BCMA target on the myeloma cell. And the side effect profile of CAR T cells is very, very different than that of a transplant. You're not going to lose your hair with CAR T cells. You can obviously get infections. You could have some neurotoxicity. You could have some drop in the counts. You could also get CRS, which you wouldn't get with an autologous stem cell transplant. But most patients tolerate the CAR T cell, in my experience, much, much better than they tolerate the stem cell transplant.
This was the case for our next guest, Amy Gebhardt. Amy was diagnosed with multiple myeloma in August of 2018 and started induction therapy with Velcade, Revlimid, and dexamethasone. After a couple of months, her oncologist switched out her Velcade for Kyprolis in the hopes of achieving a faster response. In February of 2019, she underwent a stem cell transplant and achieved a stringent complete response, which means that there were no detectable plasma cells in her bone marrow or myeloma proteins present in her blood or urine. After getting her transplant, Amy was put on maintenance therapy, which helped maintain her remission for 2 years. When she relapsed, her doctor tried several different treatments, but none helped lower her myeloma cell counts. Her doctor recommended Carvykti, a CAR T-cell therapy, and Amy was eager to give it a shot.
But with the CAR T, the nausea and vomiting was not nearly what it was for the stem cell. So like when I'm comparing the two, I might have had some nausea. I definitely didn't have the vomiting. For the stem cell, I was 6 weeks in struggling with that every single day, multiple times a day. So that's what I really hated about the stem cell transplant. With a CAR T, I didn't have that to that degree. I might have had some nausea, but it was able to be managed with the oral medications. Fatigue was a big one, and just, being able to get up and move and walk and try to push myself to do those things to try to make it better. Just an overall feeling of not feeling well for the first several weeks, as it went through and killed off this cancer in my bones. But I just remember I had my husband take a picture of me on day 30 because I was feeling so good and I just wanted to celebrate. And I couldn't believe that I felt that good after just 30 days.
There are 2 CAR T-cell therapies currently approved for multiple myeloma. Idacabtagene viclucel, sold under the brand name Abecma and sometimes referred to simply as Idacel, and ciltacabtagene autoleucel, also known as Cilta-cel and sold under the brand name Carvykti. As Dennis described, both therapies targeted the B-cell maturation antigen, or BCMA, on myeloma cells. Abecma is approved for patients who have received at least 2 prior lines of therapy and who are triple-class exposed, meaning that they have already been prescribed and become resistant to a proteasome inhibitor, for example, Velcade, Ninlaro, or Kyprolis, an immunomodulatory agent like Revlimid or Pomalyst, and an anti-CD38 monoclonal antibody like Darzalex or Sarclisa. Carvykti is approved for patients who have received at least 1 prior line of therapy that included a proteasome inhibitor and an immunomodulatory drug, and who are refractory to Revlimid. CAR T-cell therapy is given as a one-time infusion. If a person achieves a response, no additional treatment is needed during their time of remission. After Amy received CAR T-cell therapy, she achieved a stringent complete response with minimal residual disease, or MRD, negativity, meaning that a highly sensitive test did not detect any myeloma cells in her bone marrow. For 1 year after her CAR T-cell treatment, Amy did not receive any other myeloma medications.
That was amazing. That was amazing. I felt like, okay, good. Like I have a period of time that my body can kind of clear out all these, the treatments are great and they control the cancer, but they're also toxic, right? So, nice to give my body a break for whatever period of time I was going to get. Of course, that year went by way faster than I was hoping. And, I do try to appreciate and take advantage of my remissions when I'm in them. Because when I'm not, the treatment is pretty all-consuming.
CAR T-cell therapies are just one type of immunotherapy available to myeloma patients. Another type is bispecific antibody therapy. Like CAR T-cells, bispecific antibodies, which are sometimes referred to as dual-specific antibodies, bifunctional antibodies, or T-cell engaging antibodies, work by boosting the immune system's ability to attack myeloma cells. Bispecific antibodies can simultaneously bind to surface markers on 2 different types of cells. One piece of the bispecific antibody binds to a marker found on the surface of myeloma cells, like BCMA. The other piece of a bispecific antibody binds to the surface of T cells. Ultimately, bispecific antibodies bring T cells and myeloma cells close together, making it easier for the T cells to recognize and destroy the myeloma cells. Unlike CAR T cells, bispecific antibodies do not have to be personalized to the patient, that is, engineered in a lab. They can be used off the shelf. There are 3 bispecific antibodies currently approved for use in multiple myeloma. Teclistamab, sold under the brand name Tecvayli, elranatamab, known by the brand name Elrexfio, and talquetamab, known by the brand name Talvey. Both Tecvayli and Elrexfio are BCMA-targeted bispecific antibodies, whereas Talvey has a unique target on myeloma cells, GPRC5D. All three are approved for patients with relapsed or refractory multiple myeloma who have received at least 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 monoclonal antibody. Bispecific antibodies are administered through an intravenous infusion or via injections and, unlike CAR T cells, which are a one-and-done infusion, require ongoing administration. When Amy relapsed after her CAR T cell therapy, her doctor recommended a bispecific antibody. She was initially started on a BCMA-targeted bispecific, but did not see a response. She then received Xpovio for 5 months, after which her doctor recommended that she switch to Talvey, a bispecific antibody that targets GPRC5D.
Luckily, another FDA approval came through, and that's when we looked at the talquetamab bispecific that would go after a different target on my cancer cells, and with hope that because of that, this would work better for me. And so I started that at the very end of December of 2023.
Amy's myeloma counts began to drop, and she is still on the GPRC5D targeted therapy today.
With talquetamab, the first 6 weeks were really challenging. I didn't feel well. But again, part of that is that it's killing all that cancer, and so you're not going to feel well when you're trying to do that. But after the 6 weeks, it was almost like a light switch was turned on, and I just felt so much better. Started getting energy back again, and felt like I could do more. I didn't have any nausea or vomiting with the bispecifics, which was nice.
Both CAR T-cell therapy and bispecific antibody therapy are immunotherapies, that is, treatments that harness a patient's immune system to kill myeloma cells. Because of this, some of the side effects seen with these therapies are caused by the immune system becoming superactive. These include cytokine release syndrome, or CRS, an immune reaction caused by the release of proteins called cytokines into the blood, which can cause fever, nausea, headache, rash, a fast heartbeat, low blood pressure, and trouble breathing. Neurotoxicity, which is damage to the nervous system caused by exposure to certain substances, can also result, leading to headaches, confusion, and altered levels of consciousness. Low blood cell counts and infection are other side effects that can occur with immunotherapy. In most cases, these side effects are very manageable. They can, however, require more aggressive therapy in some patients, so all patients must be monitored in the hospital during the initial stages of treatment.
For CAR T, well, I think in the future we're probably going to learn to do this outpatient, but I think it's just because of the risk of CRS, the risk of neurotoxicity. I think it's when you ask yourself what's the safest option, I think the safest option is for them to do this in the hospital for now. I think that might change, but I think for now the safest thing is for those patients to be admitted in case they have any acute complications.
CRS is the most common side effect seen with these therapies. In about 70% of cases, it is considered mild and manageable. Most patients with CRS develop a fever, but others may develop symptoms like low blood pressure, low oxygen levels, and shortness of breath. Severe CRS reactions are rare, but they can be life-threatening. Because of the risk of severe reactions, patients require frequent monitoring while receiving treatment. Therapies are available to treat CRS if it does occur.
So CRS stands for cytokine release syndrome. And what it is it's pretty much the immune system kind of goes into overdrive. And some of the signs and symptoms of CRS is, well, grade 1 would be just a fever, but then you could also develop some hypotension, which is low blood pressure, fevers, chills, and sometimes that blood pressure could get so low when you're in the hospital that sometimes it won't respond to fluids. So patients would have to go on what we call vasopressors, which would be more like grade 3 or grade 4 CRS.
Amy experienced CRS after she received her CAR T-cell therapy. Her healthcare team had warned her that these types of reactions were a possibility after immunotherapy and were carefully monitoring her after her CAR T-cell infusion.
They had this iPad and that was connected to the clinic. And so I would have to take my vitals every certain hours of the day, like 4 or 5 times a day. And except for when I was in the clinic, I would take those and I would answer these questions, and then that would all transmit. And if there was anything that was concerning, then the nurse would call me right away. So that was how they were able to monitor it so closely with me not being in the hospital.
The first sign that Amy was experiencing CRS was a fever over 100.4 degrees. She called her doctor immediately, who sent her to the hospital for emergency care.
It was CRS grade 2, and I was in for several days because they it almost got to the point where I might have had to go to the ICU to be put on oxygen. They gave me 2 doses of Toci to get it under control, and then they put me on a regimen of dexamethasone to help manage it. The second dose of Toci was what really knocked down the fever. I think I was up over 103 for a day or two. I was just delirious.
After starting her second bispecific antibody, Amy was hospitalized for a few days while her healthcare team got her symptoms under control.
And I wasn't scared of that because I had had it with the Carvecti, but it was just for one day, and the fever wasn't as high as what I experienced with the CAR T. They gave me a dose of Toci, and then I went on dexamethasone for a little bit. All of that resolved it pretty quickly. It was a high fever of 101 or better, and then low blood pressure. Those were the 2 main symptoms. No neurotoxicity at all either, which I've been very thankful for.
Neurotoxicity, another possible side effect, can occur in immunotherapy when the immune system affects the central nervous system, which can lead to symptoms ranging from headaches to seizures to changes in mental status. Neurotoxicity is sometimes referred to as immune effector cell-associated neurotoxicity syndrome, or ICANS, and it is more common with CAR T-cell therapies than with bispecific antibodies. When it does occur with bispecific antibodies, it typically happens during one of the first couple of doses.
So what ICANS is it stands for immune effector cell-associated neurotoxicity syndrome. And this can happen after CAR T-cell. We really don't see much of it with bispecifics, but there's a grading system called an ICE score, and that kind of differentiates like how bad the ICANS is. You could have like some encephalopathy, some aphasia. So it's important for these patients that once they have these signs, and this is why we like to do this inpatient, is that you can get very, very quick workup. So you can get CTs of the head, you can get MRIs of the head, you can do blood work and get the results right there. So that's why I don't know if CAR T, I can't say for sure ever, but I don't know for now at least that this is a big reason why we do CAR T in the inpatient setting, even though it's really not super, super common that we see this. But again, you kind of have to practice safely. So that's why we like to do this in the hospital.
Monitoring of neurotoxicity is important, and options for management are available. Serious symptoms can develop, but most cases resolve on their own or with treatment. Because the risk of neurotoxicity continues even after patients transition to outpatient care, patients and their caregivers need to monitor for symptoms and alert the healthcare team whenever symptoms are seen.
If patients ever do develop neurotoxicity, we always get a neurologist on board in the hospital. Depending on what's going on with them, we can give them tocilizumab. Sometimes we'll give them steroids. We'll obviously do imaging of the head to make sure that everything is okay. The nurses do ICE scores, which kind of evaluate the severity of the neurotoxicity. So they get the $1 million workup while they're admitted. And usually it does subside after a certain amount of time in the hospital. And then once they go outpatient, this is not something that we see that kind of reoccurs. They kind of just get it initially when they get the CAR T cells, and then it kind of runs its course, and then we see them. I have not had a patient to date that has had any lingering neurotoxicity side effects from the CAR T.
Because of the risk of CRS and neurologic side effects, patients receiving treatment with CAR T cells or bispecific antibodies must be monitored daily, usually in an inpatient hospital setting. Patients receiving CAR T-cell therapy are monitored daily for signs of CRS or neurotoxicity for 7 to 10 days after infusion and are instructed to remain near the hospital for at least 4 weeks after infusion so they can receive regular monitoring. Patients receiving bispecific antibodies are hospitalized for 48 hours after they complete their step-up dosing so that they can be monitored for side effects. All patients receiving either type of immunotherapy are instructed to carry a wallet card that instructs them to seek immediate medical care if they experience specific symptoms. Caregivers are vital to recognizing symptoms, so it is important that they familiarize themselves with the signs and symptoms that are listed on the wallet card. Another possible side effect of both CAR T-cell therapy and bispecific antibody therapy is a drop in blood cell counts. This is thought to occur when activated immune cells enter the bone marrow and begin attacking myeloma cells. This may also result in stunting of the bone marrow cells, which are responsible for producing the body's blood cells. As a result, a drop in blood cell counts can occur.
With the BCMA-directed bispecifics and even with CAR T-cell, like with CAR T-cell, you can have a drop in counts for a while. It could be anywhere from a month to 3 months to 6 months. It could even linger for a year to have low counts, pancytopenia. It doesn't mean the patient's going to need blood transfusions or platelet transfusions. It's just something to keep an eye on, that their levels probably may not go to normal. And like I said, some patients, we've had that a year out and they're still pancytopenic. Other patients, after maybe 3 months or so, their counts kind of go back to a normal level and they're kind of out of the woods at that point. And the same thing goes for the bispecifics. I mentioned before that patients who are starting BCMA-directed bispecifics, we in our clinic, we see a drop, like at some point during cycle 1, the patient can become more neutropenic. But then for some reason around cycle 3 or cycle 4, I think it's just because the body is maybe just adjusting to the drug. We really don't see that neutropenia anymore. So we don't really have to give those patients growth factors. We still check CBCs and CMPs every time we give the dose, 100%. But it's not, but we just, something that we clinically see as the typical pattern is it's mostly more prevalent up front. And then after a few cycles, it kind of just subsides.
In some cases, such as Amy's, blood cell counts may take a while to recover. Transfusions or growth factors can help during this time.
I had low blood counts after CAR T, and it took quite a while. It took about 6 months for those to recuperate. Up to, can't say that I went into the normal range, but I got close. And that stayed that way until I relapsed again, and then my numbers went down. And typically, if my neutrophils would be below a 1, then I start doing Neupogen shots to help bring it back up.
Changes in blood cell counts can lead to a number of other complications. For instance, if a person's neutrophil counts drop, it may increase the likelihood of developing a serious infection. Antibiotics or antifungals may be needed during this time.
We've seen almost everything. So we've seen pneumonias. We've seen a lot of URIs such as enterovirus, rhinovirus. We've seen a couple of metapneumoviruses, which could be a nasty virus, RSV. It just makes you just more compromised in general. And then you develop these upper respiratory infections. But I think we're getting smarter on how to manage these things and how to prevent them. And I think the biggest thing is to keep the IgG levels adequate and really monitor those patients for neutropenia.
Low blood counts and infections can develop with either CAR T-cell therapy or bispecific antibody therapy. However, because bispecific antibodies are administered continuously, the risk for serious infections is higher for this type of therapy. More than half of the people receiving bispecific antibody therapy develop a serious infection requiring significant intervention, such as hospitalization.
We like to give IVIG, supplemental IVIG, if those immunoglobulins drop below 400. Now, I will tell you in our practice, I'm a little bit more kind of strict on how I give IVIG. So in other words, I won't wait all the time for the IgG levels to drop below 400. If they're around 500 and they're just kind of starting, that's why I like to see those patients on day one. Because if they have a starting point of 500 or high 400s, I'm going to start them anyway because they're going to drop. So I'd rather just be safe than sorry than do a whole cycle, wait to get the IgG levels. Now I see they're 200. and now the patient's more at risk. So I'm a little bit more strict when it comes to the IVIG. Other things we do to kind of mitigate infections is we put patients on prophylactic antimicrobials. So we always do PJP prophylaxis with Bactrim Monday, Wednesday, Friday, and we also sometimes do Levaquin 500 milligrams a day for the first few months. And then as we see that the ANC is recovering and the IgG levels are adequate, we can scale back on the Levaquin. But a lot of times we'll do this for the first few months. And all of our patients are on acyclovir prophylaxis, which is an antiviral.
These side effects, CRS, neurotoxicity, blood count changes, and infection, are common to all CAR T-cell and bispecific antibody therapies. Additionally, the GPRC5D targeted bispecific antibodies can also cause unique side effects in the skin, nails, and mouth.
So talquetamab is a GPRC5D targeted bispecific antibody, and unfortunately, we have this antigen also on our skin cells and our oral mucosa cells. So some of the big side effects that we can see is dysgeusia, which is they lose their sense of taste, skin changes, nail changes. So this is one of the big problems with the drug. The drug itself works great in terms of controlling the disease, but there's a lot of toxicities with this drug, right? So we're still kind of figuring out how the right way is to manage these patients. Of course, there's amlactin lotion that we give patients who have any type of like skin disorders. The nails, trying to keep the nails clean. Mouthwash. I mean, we tell patients try to keep their mouth moist, but in reality, there's really not a whole lot that has been proven to really work, except for cutting down on the dose or cutting down on the frequency of the drug. So the way the drug is given is it's either given weekly or it's every 2 weeks. We have a lot of patients that we have to dose reduce and reduce the frequency of the drug to maybe every 2 weeks. And we actually even have some patients on monthly dosing. And what we've seen is a majority of patients are actually able to hold their response. And the side effects, actually, the toxicities actually get better the more you spread the drug out. So we will try to, at least in the upfront setting and initially given the drug, we will try to stick with the FDA label and given either 0.4 weekly or 0.8 every 2 weeks. But then we will, depending on what the response is, we're pretty quick to kind of decrease that incidency and the frequency of the drug.
As Dennis mentioned, oral side effects may be managed with over-the-counter sodium chloride mouthwash and artificial saliva spray. If taste issues disrupt normal food intake, patients and clinicians should be sensitive to weight loss and take steps to ensure good nutrition through therapy. For patients with taste disturbances, the healthcare team may encourage patients to set reminders to eat regularly and stay hydrated. For some patients starting Talvey, the healthcare team may recommend consultation with a nutritionist for support in managing issues with taste that could affect diet and eating. Amy experienced a loss of taste after starting on Talvey. Fortunately, it did not cause weight loss.
I lost my taste. I can't say that I've lost it 100%. There are certain things that cut through. Sometimes sweet things I'll notice I can taste a little bit, and spicy things I can taste a little bit. My liking of certain foods has changed because it's more of a textural thing now. So if I don't like the texture of it, then it's, not a good experience. Bananas. I used to like bananas, and now I don't like them at all because it's such a bland flavor, and then the texture just not good anymore. But salads, I love salads. And the texture of the lettuce, like I guess that kind of crunchy, like bread, I don't really like now either too much. It doesn't have really any flavor for me, and the texture just doesn't. And I used to love bread. I used to love dipping it in olive oil, but none of that has any flavor now. My nurses were worried that I was going to lose a lot more weight. I lost 20 pounds when I was on selinexor, but I haven't. I've been able to maintain. I'm still hungry. I haven't lost my appetite, so that's good. And I can still smell. So that helps with being able to eat. But it's definitely, I've changed some of the things that I eat versus don't eat. But that hasn't bothered me as much as I thought it would. And as for nails, I do have some splitting and chipping. And I do have a ridge where you can tell the difference between the thickness of my old nail versus the thinness of my new nail that's growing out. So I haven't lost any nails at this point, and it's really only noticeable to me. So that hasn't been an issue.
Amy says that even though the side effects are challenging, her myeloma counts are down, and she chooses to view that as a positive thing as the medication does its job.
Well, the way that I look at it is that if I didn't do a treatment, then my cancer would continue to grow, and I'm going to feel pretty lousy just from the cancer itself. And then I could start breaking bones again, which would cause more surgeries and greater issues. You have to prepare yourself for the beginning part of treatments and know that you're going to have a period of weeks where you are mainly focused on your treatment and getting well again. And make sure that you've got caregivers lined up. I'm lucky enough to have an amazing husband who's my primary caregiver, and he is there with me every step of the way, and I couldn't do it without him. But having those things lined up and just mentally preparing yourself to not feel well for those initial few weeks. But then once you get it under control again, you feel so much better and can do so much more. So it ends up being worth it. It might not feel like that as you're going through the bad side effects in the initial pieces of the treatment, but know that it's going to get better and that you'll really have much better quality of life while you're in remission.
Side effects are common with immunotherapies because of how these treatments work in the body. Some are bothersome and some may be more serious, but most can be managed with supportive care or dosing changes. If you experience any treatment side effects, it's important to let your healthcare team know right away so they can determine the best way to manage them.
So the first thing we tell the patients, we go over all the side effects with them, and we see these patients every month. So after every cycle, so each cycle is 4 weeks, we see them before every cycle. So we see them at least once every month. And if we need to see them sooner, we'll see them weekly or every 2 weeks if we have to. That's no problem. But we always tell the patients, you have to be very quick to tell us if you're experiencing any of these changes, because we don't want these to get worse. And depending on what the response is, we may be able to scale back on the frequency to see if that helps the toxicities at all.
Dennis encourages patients to be vigilant with these therapies and to have a low bar for seeking emergency care if needed.
And if they're going to an outside hospital, we always tell the patient, tell the ER doctors what drug you got, that your status post-CAR T cell, or that you had a bispecific. And then we always give our contact information so that way the ER team, the local ER team can call us and we can talk about the case over the phone.
Although side effects with immunotherapies are common, these treatments are powerful tools in the battle against myeloma, and they can provide durable, meaningful remissions.
But I feel the best I've felt in at least a year or more.
Thank you for listening to the Myeloma Matters podcast on immunotherapy adverse events, hosted by the Multiple Myeloma Research Foundation. The MMRF thanks Amy Gebhardt for sharing her unique experiences with CAR T-cell and bispecific antibody therapy, and Dennis Verducci for his insights on how to help patients be aware of and get through the main side effects of immunotherapy treatment. The MMRF also thanks AbbVie, Cure, Genentech, Pfizer, Regeneron, and Sanofi for their generous support of this podcast. If you have questions about what you heard today, please call the MMRF Patient Navigation Center at 1-888-841-6673. If you've enjoyed this series, please be sure to leave a comment or review wherever you get your podcasts. And thanks again for listening.